Hello, everybody. Welcome back to the Science Dispatch podcast. My name is Cameron English. Very excited to be with you as always, joined by Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, what is going on?
It's a lovely day again. I'm getting the sense that summer may actually be arriving shortly. This is a good thing. I have all the stuff out in the yard as required on my honey-do list, so I'm a happy guy.
There you go. Barbecues, maybe some pool time. I don't know. Is that a thing on the East Coast?
It is a thing, but I had a pool when I was younger, and I greatly resist the requirement that I get another pool. I know. The pool is very much like a boat. You know, your happy times you have it is the day you get it and the day you get rid of it.
It's good. They're like trucks. It's good to know someone that has a pool instead of having. There you go. All right.
Bang on that one.
Okay, well, let's jump into our episode. We've got a great article by our resident legal scholar, Dr. Barbara Billauer. This is called The New Hunger Games, GLP Lawsuits. So here's the introduction, and then Chuck, break this down for us. So Barbara writes, "We expected miracles. What we got was a legal minefield. As GLP-1 drugs like Ozempic reshape bodies and bottom lines, a growing swarm of lawsuits threatens to upend the billion-dollar industry. Are patients being blindsided, or is this just the next chapter in America's pharmaceutical blame game?" Excellent question. Dr. Dinnerstein, what is your answer?
So I do think it's part of America's new approach to settling all disturbances, which is to go to court and fight it out for the next 10 or 15 years. There's some interesting numbers buried away in it, but the bottom line of the story is that the GLP-1s have been safety tested to the satisfaction of the FDA, and then, as with many drugs and devices, and I would even argue government policies, it's released into the wild. And once it goes into the wild, where anybody can prescribe that for any reason, problems that didn't appear present during the safety and efficacy trials start to show up. And this becomes fodder for people who want to find somebody to blame for what is often catastrophic consequences that were not anticipated. So this is a case in terms of specific finding, and let me see if I can make sure I got the correct wording on this, for a condition called non-arteritic anterior ischemic optic neuropathy, which is a condition involving the optic nerve which causes blindness. And at least 2 individuals have developed blindness while taking GLP-1 and have decided to sue the manufacturer over it. And it raises, again, the question of informed consent. So let me put some background in that may not have been there necessarily when Barbara wrote about it. When the FDA makes a decision about safety and efficacy, it looks at the clinical trials. But because the pharmaceutical companies are interested in bringing their drugs to market, they choose a sample size which is sufficiently powered to identify the major adverse effects. And they do it over a time frame which they think is justifiable. So the data on which Wegovy, in this particular instance, was approved involved only a few thousand people and over 2 or 3 or 4 month periods. Now that we've released those drugs into the wild, we have a far larger population that's getting the drugs, and that larger population has other comorbidities, lifestyle differences, genetics, that will cause some changes in what the adverse effects are. And I think that that's how the pharmaceutical companies have gotten caught up here with the GLPs.
What's so strange here is that anytime a drug comes out, everybody who follows it or has some expertise or at least some familiarity understands that there's going to be benefits and there's going to be risks. and there's going to be side effects that either weren't anticipated or you just, for one reason or another, you didn't uncover it in the clinical trials that FDA required. And now that seems to be fodder, as you said, for litigation, regardless of what happens. And it's not to minimize the severe side effects that have affected a handful of people, but we seem to take things that were just standard knowledge in medicine a few years ago, maybe a few decades ago, and now we treat it like it's this shocking unveiling. And I don't really know what to make of that. What do you think?
Okay, so there's a few things we can talk about. So one is there's a book called The Voltage Effect that talks about how, and it talks primarily about policy, how studies around policy are carefully crafted and supported, and that they can show a significant effect. But when that effect is then applied to large populations, the impact is lessened. And I think that is similar for pharmaceuticals, except in this case, in addition to the primary effect of the drugs lessening, meaning that instead of losing 20% of your body weight, you only lose 15%, there's also an increase in the adverse effects going up. So the study that they looked at, that's the basis of all this contention, has the following interesting numbers in it. The baseline incidence of this particular disease in the American population is anywhere from 2.3 to 10.3 people per 100,000. That's 0.01%. That is a vanishingly small number. When they compare it, patients with diabetes to patients without diabetes, there's about a 60% increase in that incidence. And in the studies that were reported in JAMA, which will become part of the expert testimony that the court will hear, the risk of this condition was somewhere between 4 persons per 100,000 and 7 persons per 100,000. Those are very difficult numbers to understand, let alone deal with. So I put it together in this way. I took a city of 8 million people, which is roughly the size of New York City. The baseline incidence of this disease is 824 people. Of those 824 people, if all of New York had diabetes, all 8 million, that number would rise to 1,300. This is a very small population here. If they looked and the study looked at a very inclusive diagnosis that kind of gathered as many people as they could, that would suggest that in the city of New York, 568 people would develop this problem. With a more restrictive diagnosis that was a little bit more specific, and therefore you would have a better, you would have a lower false positive rate. The number would be 336. So the question facing a clinician is, if I'm dealing with a patient, do I have a need to discuss with them an adverse effect that has a risk of 0.01%? Is that a reasonable concern? And I have to say that I don't think that it is.
Barbara makes the point that these suits are actually going to be very difficult to win for the plaintiffs. And a lot of it seems to come down to just how new the drugs are. And the fact that some of the things they would have to prove, they'd basically have to go back in time. So, for example, the claims are premised on the argument that the companies failed to warn consumers about these risks that we're talking about. And she says it'd be really difficult to show that Novo Nordisk or one of these companies that they knew that this could cause blindness and they hid it. It just seems unlikely given the way, how rigorous this research has to be these days. And I'm sure these companies are anticipating that they're going to get sued, no doubt, when they put a new drug on the market. So
that's what gets at the clinical efficacy trials. There's the tension between the perfection of enemy. Perfection of enemy is good. And They need good to get past the FDA. They do not need perfect. And so that their sample size is smaller. I mean, when you look at the studies that are in JAMA, these are retrospective evaluations of a population of 36 million individuals with diabetes. They didn't look at anything near 100,000 people with or without diabetes to show that these drugs were safe. Moreover, there is a time component to this too. So I think that I think you're right that it's going to be very hard for them to argue that the pharmaceutical companies should have known that was the case. I went back, I looked at the package insert, and the package insert has a black box warning right at the top, and that's the most significant warning that you can put on this, talking about the development of thyroid cancers and other associated cancers, and making it very clear that you have to discuss that and search for that on an ongoing basis. So it's not that they weren't looking. Now, Barbara's caveat that that there may be some hanky-panky in the background is certainly based on what we've seen in the past, certainly with the smoking, with tobacco, where they repressed a lot of science that they were aware of. There's evidence now that Johnson & Johnson knew for several decades that there was asbestos in their talc products. And if they go down over talc causing cancer, it's because of not reporting this out once they discovered it. But I would be wildly surprised if there's some knowledge by Novo Nordisk or any of the others, because it's just such a small risk that until you release it into the wild, the chance of discovering it is low.
I think if I understand her point, that's what she's saying, is that, even if it does show up, the fact that they didn't report it, it's just likely that the trial size was too small or whatever right. Technical methodological detail. The other thing she says is that, what's really difficult to prove is that, okay, say they had warned you before this condition developed, would you have still taken the drug? And given the vanity involved here and the seriousness of obesity in many cases, I find it hard to believe that people would have looked at a warning like that and went, oh, I better not take this because I'm okay, right. Being morbidly obese. So in other words, whatever you think of that, she seems to be arguing it's almost impossible to do that, to basically say, no, I wouldn't have done it if they had told me. What do you think of that?
You can say it. I don't know that you can say it with a straight face in court, because you're taking the drug because it's going to reduce your risk of a heart attack by 15%. Your chance of having a heart attack is probably 10-20% to begin with. The risk of this is, as I said, 0.01%. If you take the drug, it will rise to 0.2% on a good day. And those numbers are just not numbers that anybody can, I think, treat rationally in some kind of trade-off discussion. Certainly from my experience as a clinician, this would not be a side effect that I would even bring up. This would be part of that wave of the hand. Yeah, other things can happen, but the critical ones are A, B, and C, and that's how people would make their decision.
No doubt this is just the opening salvo. The plaintiff's bar is infinitely clever, and so I think what's going to happen here is some of these are going to get shot down, maybe most of them will be, and then they're going to come back and they're going to go, okay, well, now new studies have been done. Now we have better data. They're going to come up with interesting angles to try to sell this to juries. And I'm wondering if that's going to work. And if it works, what I'm concerned about, as she points out in the article, is that for whatever harms they could cause, these drugs are clearly making a dent in obesity rates. They're clearly reducing the risk of, I don't know if she saw incidents of heart attacks or if it's cardiovascular events that she talks about there. So in other words, it seems to me that so far, at least, the benefits far outweigh the risks. And
I think that
go ahead.
You're correct. Absolutely correct. One way from your usual cynicism, we can argue that this really has to do with a fight between deep pockets. Novo Nordisk has huge pockets now. This has been a way past a blockbuster drug for Novo Nordisk. The question is whether the class action plaintiffs bar is going to have sufficiently deep pockets to want to continue to fight back and forth in court over this. And the other issue, and Barbara's brought this up before, and we probably have talked about it, is the fact that these very nuanced science differences are going to be judged by a judge and jury, neither of which have necessarily formal training in giving an informed consent, which is the other piece of this puzzle. So that's a crapshoot. So you may find that down the line that Novo Nordisk is willing to spend some money to make this disappear because it's just taking up time and interfering with their other purposes.
Yeah. I guess my cynicism is becoming well known on this show. So this would be a good question to ask Barbara, but I could imagine these individual companies will probably, at some point, if they start losing cases, they're going to try to set up a settlement and just say, you have this much time to join the class, you get this much money, let's just get on with our lives. I'm sure the plaintiffs bar would quite enjoy that. But no doubt they will then move on to the next company, right? They'll move on to the next drug. They'll copy the complaint. They'll change a few details.
Well, but, on the other hand, you can make an argument, given 0.1%, 0.01%, that the number of people that are going to qualify for this class action is not going to be great enough that it's going to cost Novo Nordisk any real money in terms of just saying, here's some money, go away, don't bother us anymore, and get on with things. But what I find more concerning is I think that one of the reasons we see more and more of these lawsuits is because we're becoming a society that is not willing to take any risks, no matter how small they may be. It's certainly something that has been made more apparent in talking about how you raise your children. They can't go riding their bicycles by themselves anymore. They have to be supervised under all circumstances. I was raised in the 50s, so we were left to our own devices, and I will admit that I don't know that we were completely helicopter patients, but we would fly in every once in a while to see what was going on. But now, everything has to be risk reduced to zero. And if it's anything more than zero, then there's a problem.
The trouble seems to be that the narrative is what matters more. So like, for example, with the talc cases, as you said, there was preliminary testing showed there may have been asbestos whether talc was mined. But then I think you wrote it up too. There was a study where they said, okay, let's compare the cohort that was exposed to that supposedly harmful talc to a younger cohort after the company switched where they were mining it from. And the increase in ovarian cancer risk was negligible.
Yes.
So in other words, even when the evidence turns up and we go, oh, there's no there, it's almost too late and nobody seems to care. As long as the story is good, as long as we've got the Aaron Brockovich narrative, Well,
and to be fair, Johnson & Johnson, shot themselves in the foot when they write, oh, yeah, there's asbestos in this, we better, do something about it, and never do anything about it. And that's in their internal communications. That sets the stage. Nobody wants to hear that there was, some kind of background hanky-panky going on. So you're right. The Aaron Brockovich narrative is what's going to do Johnson & Johnson in on this one.
Yeah. Yeah. I don't know, man. I talked to a lawyer who's litigated a bunch of the opioid suits, where we've talked about where doctors get sued by the DEA or whatever, charged with, drug distribution. and he was saying that the kind of thinking that's required to suss out these cases, you have to slow down. It's the system one, system two thinking thing, right? You have to slow down and actually think about the information you're hearing and assess whether it's legit. And the lawyers are deliberately trying to sabotage that with a story that says, there's this big bad company,
Yes.
poor little mechanic hooked on opioids or whatever. And, so that's becoming more prevalent, I guess, is the...
Well, that's the whole. That's the internet. I mean, we all love stories, and a story that hits on the gists, the emotional gists of things, are the ones that go viral. All good storytelling begins with an individual. I mean, what does it mean to go before the jury and say 0.01% of people get this? You just point over there to your to the plaintiff, who came in with the dog and the cane, and that does the work for you. But then that's what it is.
Yeah. Is this single mother just a statistic to you? Is that what you're telling me, Big Pharma? Like that. Yeah, that sells. That's a Hulu story. I could make that story.
Those parts of the narrative put the tiers to the statistics.
Yeah. Yeah. Okay, well,
another problem not solved today.
Hey, we do what we can, and we're happy to do it. Thank you, folks, for listening.
I think our track record is actually intact on not solving any problems.
It's 100%. It's 100%. You want something not fixed? Come to Chuck. Come to me. We're going to make it happen. Okay, well, I guess we'll just follow this. As another physician I know says, you can't win for losing. It's like no matter what you do, somebody's going to find a flaw in it. And it just concerns me that we seem to be kneecapping our best shot at solving some of these problems in the name of, a good Netflix story that someone can sell one day. All right. Well, once again, the story is called The New Hunger Games GLP Lawsuits. This is by Dr. Barbara Billauer. It's on our website, acsh.org. Go to the site, click the subscribe tab, punch in your email address. We'll send you the stories that we publish, and you'll be a little more informed when you show up for the podcast. Please visit our new and improved YouTube channel, which is hosted by our colleague Anna Dalaski. She's doing great videos, little 1 to 2 minute explainers of some of the issues that are in the headlines, trying to give you a science-based counter to some of the silliness. And thank you so much for being with us as always, and we will see you next week.